Okay, so if we could take our seats. So we had a fantastic start this morning to Gallie Day, some amazing presentations by our trainees. The e-poster session was fabulous. I had a chance to tour around all of the rooms, and the quality of the presentations, the interaction was really excellent. And we're kind of heading into, which is really, I think, kind of the core of focus of today's Gallie Day, and this is our Gordon Murray lecture. This will be done by Professor Liane Feldman, and we'll have a formal introduction of Professor Feldman in just a moment. So, who's Gordon Murray? And Gordon Murray is an iconic a surgeon, immensely talented, and his family has endowed this lectureship, and we're very grateful to Gordon Murray's family for doing this. Among his accomplishments, I think probably one of the most important translational research accomplishments of Gordon Murray was to take heparin, which actually had been purified by Charles Best, the co-discoverer of insulin. And Gordon Murray applied the use of heparin in vascular reanastomoses and really totally transformed the outcomes for these patients. And this actually had a very big translational impact. And I must admit that I didn't really fully appreciate Gordon Murray's role in terms of doing this until kind of done a bit of work. So just to give you a little bit of context behind the name, there's always a big story behind the name. I know that Professor Tatter, who's sitting down, always spoke also very highly of Gordon Murray's very significant technical prowess. So from that perspective, I'd like to actually call upon Dr. Alan Okranek to formally introduce Professor Feldman. And Alan is a dear colleague at the Toronto Western Hospital. He's an extremely accomplished innovator and really involved in a lot of state-of-the-art laparoscopic techniques. And he currently has an important role as the director of the Temerty Chang International Center for Telesimulation Innovation in Medical Education. And so from that perspective, Alan, if you could please introduce our Gordon Murray lecturer.
All right, good morning, everyone. It really is an honor and a great privilege to introduce this year's Gordon Murray lecturer, Dr. Liane Feldman. Dr. Feldman has been my teacher, a mentor, and a very good friend for many years. Dr. Feldman is the Edward Archibald Chair of the Department of Surgery at McGill University and the Surgeon-in-Chief at McGill University Health Center. Her clinical practice specializes in minimally invasive gastrointestinal surgery. I had the privilege of being her fellow in 2005 and really witnessed firsthand what an amazing surgeon and teacher she is. I learned a tremendous amount from her that I have incorporated in my own practice to this day and that I have taught our own residents and fellows here at the University of Toronto. Dr. Feldman has had an incredibly prolific research career focusing on improving the quality and outcomes of abdominal surgery. She has authored over 350 articles and book chapters, co-edited 3 books, has received over $4.5 million in funding support. She's really internationally recognized for her work in enhanced recovery perioperative programs, which she has led at McGill for many years, which the Ministry of Health in Quebec has implemented across the province. She's co-chaired the Enhanced Recovery and NISQIP Collaborative at the American College of Surgeons. In addition to all her leadership roles at McGill, Dr. Feldman has held many prestigious leadership roles internationally. She was the president of the Society of American Gastrointestinal and Endoscopic Surgeons. She serves on the Board of Regents of the American College of Surgeons. She led the implementation of EPAs with the Fellowship Council and was also the James IV traveling fellow for Canada. Now, on top of all these accolades, at a time when we are really, as a surgical community, promoting the importance of wellness, Dr. Feldman has always been an amazing role model in this area. She's an amazing athlete. She runs triathlons. You'll see her at a conference leading the running club in the morning. She's an amazing chef. She has a wonderful family. She is someone that has truly inspired me my entire career. I know she's been an inspiration to trainees and surgeons across the country and really around the world, and so we couldn't have been more thrilled when she accepted our invitation to be the Gordon Murray Lecturer. So please join me in welcoming Professor Liane Feldman to the podium.
Wow, that was so nice. Just see if we could get the slides up. I was thinking, Alan, I mean, it's wonderful seeing so many friends and colleagues, and there's nothing better than seeing your previous students or trainees surpass you in their activities. There's nothing better. It's like your children doing well. And I remember, Alan, when we talk about wellness, that when you were our fellow and Jolene was here and you were in Montreal, and we invite you up to the country for the weekend. And I said, you probably don't want to come. We have 3 little kids under like 5 years old. But you came and we had such a great weekend, and we'll always remember that. And you know, you did some high intensity snowshoeing. So we have to keep our wellness in all seasons. I don't know. We'll get the AI on this. Here we go. All right. Yeah, we're going to talk about mastery in surgery and some of the promises of AI using video to improve our techniques. I do want to really thank Dr. Swallow, Dr. Fellings, everyone that put this program together. For this is a true honor, I would say a career highlight for me to be in your department. I think the University of Toronto Department of Surgery is, to me, an exemplar of excellence in academic surgery in any way that you define it. And learning more about the department, I'm just continually, increasingly more in awe and seeing the poise of the presenters this morning, and I know there's more coming. Really very impressive. I know our day-to-day sometimes is filled with many, many little challenges, but when you take a step back, I think for all of us in Canada, in Canadian surgery, we have so much to be grateful for being in this country, in this environment. And truly, you are a leading international department that is really a great example to us all. So, to get started, I don't have any financial disclosures. As Alan said, I've been very involved in one of our surgical society stages, and some of the examples that I'm going to give you here today are related to work in developing video-based assessments, or VBAs, and I'm going to explain a little bit about what that is. So that will be some of my examples. I don't really have any financial disclosures, but I do have a lot of acknowledgements. I'll go through each of these. No, I won't. But just in general, you know, Alan and Amin are there. But like you or my colleagues here, we have the great good fortune to work at a university that attracts really brilliant people. And these are some of the people that research residents and fellows and students that I've had the great pleasure to work with and learn from, of course, including some of you here today. So, you know, as I get, older, you get more interested in the history And maybe Dr. Fellings also mentioned that. So we're here for Gallie Day, right, named in honor of William Edward Gallie, and I happen to hold the Edward William Archibald Chair. And in addition to sharing their first names, and I think some kind of physical resemblance, if it's not just me, I just took the pictures from the internet. Yours even looks more, they look more alike, but I think there's some really nice connections between Gallie and Archibald. They definitely overlapped in their lifetimes. Archibald was a little bit older, but I think it really represents the important relationships between the two departments. And Archibald was the first chair of the Department of Surgery at McGill. I believe Gallie was the second chair, but Archibald was about 10 years older. Really both were brilliant and innovative general surgeons with large impact in North American surgery, including both having been presidents of the American Surgical Association. Gallie was also president of the ACS. And they both gained a significant surgical experience through their war service in the First World War. We heard about the Gallie course a little bit, but both Archibald as well developed a novel structured surgical training in thoracic surgery. They both really believe that surgeons should be trained methodically and with a curriculum rather than the itinerant apprenticeship model that was prevalent in their day. And they were the first two examiners in surgery for the Royal College. And I know the general surgery residents had their oral exams yesterday. And both had an important commitment to focusing on experimentation to generate evidence. So I think, and that's what really we're here to celebrate today. And so just in that spirit, Archibald established the Department of Experimental Surgery in the hospital, at the Royal Victoria Hospital, which is a pretty new hospital in that day in 1929, been open for about 35 years. And it was to introduce an atmosphere of scientific inquiry into the hospital. And I think that still is the model that we're celebrating here today, because the encouraging cooperation between basic scientists and clinicians to come up with new approaches, innovations to difficult surgical problems. I think that's really, you know, we owe so much to the foundations that these kind of visionaries 100 years ago laid for us that we're still benefiting from today, and hopefully we are good ancestors for the people who come ahead of us as well. So we have to remember that Gallie and Archibald worked in a time for them of rapid innovation, change and program building. So we have to remember that modern surgery has come a very long way in a relatively short period of time. So it's just 180 years ago that this is a reenactment, but the first public use of ether anesthesia at the other MGH, that always gets a laugh in the States, because I'm at the Montreal General Hospital, it's the Massachusetts General Hospital, of course, and then followed rapidly in the decades that followed by Lister's use of antisepsis. So there would be no surgery without these things, and that was a really exciting time. And during this time, in part of all of this excitement, we have a quote from Sir John Ericsson, one of the most prominent surgeons of his time. But he wanted to temper his enthusiasm for these revolutionary advances being developed. So he said, there cannot always be fresh fields for conquest by the knife. There must be portions of the human frame that will ever remain sacred from its intrusion, at least in the surgeon's hands, that we have nearly, if not quite, reached these final limits. There can be little question. So even in times, like we're in this time of rapid transformation, and we have to remember that even in these times, it's very hard to imagine what the future could look like. And there's no way they could have imagined in any way what routine operating rooms look like today. And for me, from coming from the laparoscopy side, the minimally invasive surgery revolution beginning in the late 1980s, and that was the context that I trained in the 1990s, seeing surgery transform before your eyes to become less invasive, more precise, more predictable, safer, and allowing for faster recovery for patients, which means that more patients can benefit from surgery with its potential to cure or to provide durable answers to quality of life problems. And we're, I think, in this time, as we've heard, the talks you heard today, we wouldn't have heard a year ago. We wouldn't have heard 2 years ago. And so we're in this time of rapid innovation and change with the enormous potential for big data, digital technologies, robotics, and artificial intelligence to support early detection and risk assessment. We heard about that today. Improve surgical planning, transform training, provide more precise and targeted interventions, and prevent surgical errors. And the modern operating room with its robotics and minimally invasive surgical platforms, imaging equipment, monitoring systems, devices, generates an enormous amount of data, which we didn't hear, though I know we're going to hear some more examples of that later, but that's just data. It's streaming data. It's all data. And that can be the backbone of the continued evolution and transformation of surgery and interventional healthcare in general. And the development of these technologies and novel treatments will require novel collaborations and highly specialized interdisciplinary teams. And I met with one of them yesterday with Amin, and Alan was there, and a really impressive group of people coming together to solve, again, surgical problems with innovative and new ideas. But no matter what remarkable changes we've seen, operating is what differentiates us surgeons from other physicians, and this has been true for millennia. And in general, I think we all everybody here spends their lifetime dedicating their lives to perfecting their surgical skills and mastering the art of surgery. And how we learn in the operating room, though, hasn't really changed very much from the models set up by Gallie or Archibald or Halstead. Besides the cocaine of the Halstead. But besides that, we still learn this probably about the same way in the operating room. And when we look at how we get to mastery, of course, the steepest part of the learning curve, it occurs during those formal supervised training periods that were established during this kind of formal residency and fellowship training under supervision. But we all know that our techniques continue to evolve and be refined over time. But as someone that spent some time doing quality improvement stuff, our efforts have focused way more on adherence with care processes, surgical safety checklist, care pathways, and we've ignored the thing that matters most to us and to our patients is the operation itself. And part of the reason for that is because it's been difficult to study what happens in the OR. But again, that has changed in this data-rich environment of the modern OR, where it's very straightforward to record and store videos of cases and even other aspects of what's happening in the operating room. So because we're all going to need surgery at some point, if you include cataract surgery, basically everybody gets surgery. So if you or a family member needs to have surgery and you had one question to ask your surgeon, what would it be? What is it? Anyone? How many have you done? Exactly right. How many have you done? Because we know that volume and outcomes are very, very closely related. And that's been demonstrated over and over and over again. And that's not only true for very highly complex procedures, but it's also true for very routine procedures. So what we might consider bread and butter in the specialty. Like in my business, in laparoscopic inguinal hernia repair, it seems to take about 200 cases before the recurrence risk is around the same as it is for open surgery, which is a relatively straightforward procedure to master, and maybe even 400 until that improvement plateaus. That's a lot of hernias. So what is it that experts know and do differently? And can acquiring that knowledge and that skill be accelerated in some way? So if we're teaching the operating room, we all experience this every day, both as learners and as teachers, and it basically comes down to that a junior learner just doesn't see what a more experienced surgeon sees, let alone what they do. I'm saying just what they see. So they may know that, for in this case, so a lap chole, straightforward lap chole, they may know, and they read it and they watched the video on YouTube before, and they know they're supposed to begin the dissection at the edge of the gallbladder, and they know they need to stay above that anatomic landmark of uvea sulcus, but it's covered in a little bit of fat. And it's maybe not that obvious where to start. And of course, where not to dissect is as important, or maybe even more important, to doing safe surgery. And acquiring these complex cognitive schemas is really part of acquiring mastery. And I have to go to Dr. Madani's part of his PhD work at McGill, where he defined 5 domains of extra performance in the operating room, which he classified as psychomotor skills, so those basic surgical techniques, knowledge, so anatomy, the steps of the operation, the instruments, what's shown in the literature, are interpersonal skills, so teamwork, communication, leadership. He called personal resourcefulness, so self-awareness, how are you feeling this day, managing modulators of your attention, the door opening 1,000 times. You're stressed. Did you argue with your spouse that morning? Are you going out later tonight? What are your goals for this patient? And then his fifth element that he called advanced cognitive skills that manifest themselves through behaviors and actions during an operation. And these include things like surgical planning and error prevention, as well as early recognition of errors to allow rescue and recovery. So in essence, as the complexity of a task in the operating room increases, their successful execution becomes increasingly dependent on the quality of the decisions regarding what to do, so non-technical aspects of the operation, as opposed to actually how to do it, which we can learn in a variety of ways, not necessarily even in the operating room. So if I show you this video without measurement, is this an expert or is this a novice? Dr. Tatter is going to tell me. So it's a lap chole. So who does lap chole? So Alan, is this an expert surgeon doing this lap chole? No. So this is a novice. So as you may have guessed, this is my first lap chole as a junior resident. It was on a VHS tape in a box somewhere. I don't know why. And I can say the camera work is terrible. Besides the camera work, this is not a person that knows anything about how to do a lap chole. And obviously I had Jerry Freed as my mentor, very patient person who could get anybody out of any trouble and let me do this. Now this is we all can look at this basically, maybe we don't know anything about lap choles and say, this is not a master virtuoso surgeon doing this operation. Now, I have to say, it was a long time ago, and I do think I've improved a little bit. I was happy to have Alan's confirmation of that. But the question I'd like to talk about in the next little bit is can we accelerate that road to expertise, and how can we do that? So if we go back to a foundation of quality improvement, that you can't improve what you don't measure. So what tools can we use to measure how we operate in that kind of complex environment? So there's a lot of assessment tools out there, and I just want to go through some of the elements because it's going to come up in the rest of our discussion this morning. So when we look at what characteristics of, if we're trying to measure this complex construct of operating, there's the first thing we start with is what type of tool is it? Are we trying to measure generic skills that are common to all operations, like that kind of psychomotor skill, or is it going to be a procedure-specific thing? And for people that it's consistent with, let's say you're trying to develop a patient-reported outcome measure or something like that, or quality of life measure. Generic is good because you can use the same thing to measure everybody and compare. At the same time, it doesn't provide specific detailed feedback like a procedure-specific one can. But then again, procedure-specific ones have to be developed one by one for each procedure. Is the assessment, what kind of scoring is it using? Is it a checklist, like did this, didn't do this, did this? Or is it a global rating scale where you're ranking something on like a Likert scale from 5 being optimal and 1 being not so optimal? Or is it an error rating system? And what is the setting? Was it designed to use by somebody directly observing what's happening, or can it be used on a recorded performance like video? Who's the rater? Is it an experienced person? Is it a person doing a self-assessment? Is it the crowd? Is it AI? And where's the location that it's being used? It is used in the OR or outside the OR, like in a simulated environment. And really importantly, the intended use of the instrument. So whether it's intended for what's called formative assessment in education, which means to provide feedback during training, which is a relatively low stakes situation, or whether it's going to be used as a summative assessment, meaning to demonstrate evidence of competency, like at the end of training. And that would be used for certification or credentialing, or after you've learned a new procedure and you want to introduce it. So obviously that's a much more high stakes scenario, and it would require much more robust evidence to support validity and reliability of that tool. So we now have more and more evidence about the clear relationship of operative performance and patient outcomes. So this is a landmark study, the Berkmeyer study from Michigan Bariatric Surgery Collaborative. And it's a little over 10 years old, but I think it's a really important study. So I'd like to go through it in a little bit of detail. So in Michigan, they have a large quality improvement collaborative, and they have one of these for bariatric surgery with a large registry of patient outcomes, and it covers most of the patients in the state because they basically have one insurer in that state. who funds this. And they had 20 surgeons. They asked to submit, give me a video of your typical gastric bypass. So generally, you'd pick a good one to submit that. And then each of the 20 videos, they edited to just keep the 3 main steps, so creation of the gastric pouch, the gastrojejunostomy, and the jejunojejunostomy, and they're edited down to between 20 and 45 minutes. And then edited videos were then, they made this kind of platform, and they asked for peers doing bariatric surgery, they needed at least 10 per video, to assess the video performance using the OSATs, which was developed here under Richard Resnick's supervision. It was actually developed to rate skill in benchtop models using OSATs. And so this it assesses generic skills like respect for tissue, exposure, instrument handling, time and motion, and overall technical skill, and each is scored from 1 to 5. So first of all, you can see that if you have the you have the surgeons or the videos on the x-axis, and you have the average of the 6 ratings on the y-axis. And first of all, you can see there's a very wide range of skill ratings for the 20 surgeons. These are all surgeons in practice. And they divided these into quartiles, so the bottom, top, and then they combined the middle two. And this is the punchline. So they looked at the complication rates from their registry, and there was a very clear association between surgical skill rating and risk-adjusted complication rate. And this was the case for all complications, for surgical complications, and medical complications. And very importantly, video rating of skill, this very, very simple measurement tool, was more predictive of complications than fellowship training, surgeon volume, and years of experience. And this has now been replicated in other studies. This is a systematic review we did after that, and we found 10 studies published after Berkmeyer in a wide variety of procedures, upper GI, colorectal, Whipple's, using a variety of these kind of performance measurement tools, usually mostly generic, but some procedure specific. And 7 of the 8 confirmed this association between OR performance and short-term outcomes like complications. And some studies also showed a difference in lymph node retrieval in colectomy or higher pathologic success like in rectal cancer surgery. And so this, you can see where this is going. You can also look at longer-term outcomes, and 4 of the 6 studies that we found when we did this review showed an association between intraoperative performance and longer-term outcomes, including cancer survival or functional outcomes, urinary continence after prostatectomy. So if we can measure performance from video, and this clearly relates to outcomes, why aren't we all taking advantage of this precious resource for learning and for quality improvement? Well, this is one of the reasons, as I mentioned, I've recorded a lot of cases over the years, being interested in education and surgical technique, and we started with, I don't know if anyone remembers what a VHS tape is. Half the room, well, maybe a third of the room does, and the rest don't. And then we went to the DVDs, and you can see there's thousands maybe of cases that we have recorded, which you've never looked at for the most part. Most of the time they ended up in a box that I had that I don't know why, which one got to make it into the box, but I carried it from office to office as I've moved around. And obviously this is part of the problem, so it's very hard to organize this data, it's not integrated into our workflow, it's hard to access, it's hard to edit, and it's not available when you want it. Now some of these logistical issues are solvable by having these video storage platforms, and a number of these have emerged from research groups or nonprofits or commercial entities. And this facilitates the ability to capture and store these data streams and improve their accessibility. Basically we have this rich data environment in the OR with streaming video from like our OR tower where we're looking at the images. We could have kinematics data, which is fairly easily available from robotics platforms, so how we're moving around. Data from devices or hemodynamics, imaging data, and then of course even external recordings of the room. And these are captured by a recording device and then automatically uploaded into either a cloud-based library or an institutional library or potentially linked to the EMR. And as large amounts of data are uploaded, you can begin to apply data science techniques like we started to hear about this morning, like machine learning or computer vision in this instance to analyze these data, and then maybe we start looking at more automated performance of quality and even of surgical performance. And there's a lot of these platforms available, and more coming all the time. So this correlation between intraoperative performance and outcomes suggests several opportunities, I think. So it includes using video to provide assessments that could then be linked to focused coaching to improve performance. Something more controversial would be the ability to set benchmarks to confirm competence prior to independent practice. Another interesting concept is to be able to identify the surgical technique that leads to the best outcome. So a room full of surgeons will argue, at least in general surgery, nothing will fill the room like appendicitis, hernia, and gallbladder surgery, and everybody will argue about exactly what element of the technique is required to get their amazing outcomes. But this is a chance to potentially put some data behind that, and I'll give some examples of this. And finally, having these cloud-based storage platforms enabling surgeons potentially from all over the world in so many different contexts to share and learn from each other's videos. And it also creates the ability to collect the vast amount of data that are needed to apply robust computer vision algorithms and move forward this ability to predict outcomes, assess performance, and maybe even augment intraoperative decision-making to hasten that journey to expertise. So let's start with the coaching idea. This is from that great surgical journal, the New Yorker magazine. And Atul Gawande, who's a surgeon, but he was writing for the magazine, and he noted that we don't have people watch us operate after training. And this is really different than other performance professions, like top athletes or musicians who never stop being coached. They always use video no matter what phase of their career they're in. And now, of course, that's augmented by AI performance analytics. So we know that video-based assessments and coaching can work. This is actually an RCT from here again, where residents were randomized to regular training or to individualized coaching. And a cornerstone of the coaching was based on videos of them performing a jejunal hand-sewn. So the enterotomy was hand-sewn, so part of gastric bypass. And these were reviewed in a blinded fashion and scored using a variety of tools like OSATs and a more procedure-specific OSATs and error counts. And at the end of the rotation, the residents in the coaching group had improved surgical skills. So this is the control group, this is the coaching group, blue is before and orange is after. So the residents in the coaching group had improved surgical skills and decreased errors, while no difference was seen in performance of the residents undergoing standard training, which is somewhat concerning in and of itself, but maybe that's another talk. But it takes a long time. Preparing the videos took about an hour and a half to prepare the video, to do the scoring, to find the elements where the coaching was going to be given, and then another 25 minutes to delivering the intervention. So that might not really be feasible in terms of scalability. And I'm always telling residents and fellows to review their own videos. So we also wondered if that was helpful. So is there a role for self-assessment? So this was a pilot RCT that we did to see if a full-scale RCT would be feasible. And these were general surgery residents performing lap chole under supervision, but they were the primary surgeon. And in the control arms, the trainees recorded and uploaded their videos to the storage platform, but they didn't have access to the video. And the intervention group had access to their videos, and they were also trained to use these assessment tools themselves. We used goals, which is very similar to the OSATs. And both groups were also evaluated by the attending surgeon who didn't know what group they were in at the end of the operation. The primary outcomes, this is a pilot RCT, so it's feasibility, but we did use multivariate linear regression to assess our exploratory hypothesis we would use for sample size calculations, but regarding the difference in skill between the two groups from the first video to the third video. And the trainees were interested in using this, so 80% of trainees spent time on the platform reviewing their videos, and for an average of about 45 minutes. And we did have a lot of technical issues, but because of manually uploading to the platform, which is an issue. But our exploratory analysis showed that the intervention group on average improved by 4 points more than the control counterparts on the goals assessment, and 0.7 points more, and these are both higher than what we think is the minimally important difference on those tools. And we would need about 110 residents to do a full-scale RCT, so anybody who wants to do that, let's do it. So reviewing your own videos is probably useful. Now, major organizations in North America are becoming interested in the potential for video-based assessment and coaching to improve skills. This was a task force that I was involved in at the American Board of Surgery. It was a pilot project to look at feasibility of this concept for surgeons in practice, and included close to 300 surgeons. It used 3 different platforms, and participants submitted their videos, and then they were rated by peers using that OSATs, and also could give comments, and 75% of the people who participated felt it helped their practice, and almost 70% felt they learned something new. But there were many barriers to adoption. That this impeded even the ability to participate in the pilot for many people. So privacy concerns, hospital security concerns or firewalls, technical difficulties in recording and uploading videos, patient consent, medical legal considerations, and the lack of risk adjustment when you're being scored were all things that came up as real problems. But in the end, in the survey, over 80% of surgeons that participated said they would participate in this review if they, for CME credit, for example, or in lieu of the current continuous certification requirements that the American Board of Surgery has. So that was promising. So I want to touch on now the use of video-based analytics potentially for credentialing or certification, which for sure is a bit of a more touchy subject. So one important issue if we're going to start using video-based assessments for competency decisions is that we don't really have a whole cadre of assessment tools to measure performance that cover all the domains that Amin Madani told us are important in expertise. So the generic tools can correlate with outcome, but they don't give any feedback, and they don't cover all of the domains. They only cover psychomotor domain. And I think that surgical societies will play an important role in filling this gap. SAGES is a surgical society interested in GI surgery and has embarked on developing some of these tools. So the first one that we wanted to develop was for fundoplication. And we looked for existing tools, and we couldn't find any that would have enough validity evidence to be considered as part of competency decisions. So we decided to create your own, which it's probably not that advised. It takes a long time, and that's why, surgical societies are probably best positioned to do that. It turns out that creating something like a video-based assessment that's supported by the amount of validity evidence that's required is a lengthy and involved process, but just to give you an idea of what's involved, so this was for laparoscopic or for fundoplication in general. It started with semi-structured interviews of 42 experts across all practice types, ranges of experiences, different countries, to obtain consensus on the procedural steps, the required skills and common errors. And then this was organized into a questionnaire that another 200 surgeons filled it out to quantify how important each of those things are and how difficult they are. Through this process, we identified the 5 key steps, the sub-steps, the skills, and the errors. And we put this together into a rubric that has the 5 steps in the columns: hiatal dissection, fundus, mobilization, et cetera, the 5 steps that were determined to be potentially could be important in setting for competency decisions. And then for each step, we called QRS, so we would be evaluating skill, safety, and quality, like the end result of that step. So it was the closure of the hiatus secure is the correct part of the fundus used for the wrap. And then we worked with expert fundoplication surgeons to refine it and try it out. We had to develop a rater training platform so that we'd have a shared mental model for the people doing these assessments and have them a chance to practice. And then we had to have a consensus process to have a cut score, because this is a summative assessment. You pass it or you fail it. It's not to give coaching on each of the steps. So we have to have a transparent, robust process to do that. And we're developing 2 others in the pipeline. One is cholecystectomy, only 3 different areas, and we're fairly along the way for cholecystectomy. We're doing the rater training platform now. And the next one will be for right colectomy, which we've done the literature review, the interviews, and the task inventory questionnaire, so we should have a rubric pretty soon. And we're going ahead with a pilot to put some of this together for the graduating fellows this year, by offering access to a novel platform for video upload and embedding the fundoplication VBA. There'll be 2 experts that review it, and it's just a pilot. It won't be involved in whether you get the certificate or not. We want to see how this works. And the fellow will get the pass-fail decision, but it won't be involved in whether they're certified or not. So another area for the use of surgical video is to identify optimal surgical techniques. We know there's a lot of variability, so having video linked to outcome data may allow these different techniques to be compared. I think this was a really cool study looking at risk factors for delayed gastric emptying after robotic Whipples. And they looked at 190 videos, and then 20% of their patients had delayed gastric emptying. And they included some clinical factors, but they also performed a structured video review that revealed the technical variables associated with decreasing the risk of delayed gastric emptying, including the flow angle. So I don't know if you've ever been doing a gastrojejunostomy, but do it this way, do it that way, put it on, anterior, put it posterior. So this showed from their video that the flow angle, so if it was within 30 degrees of vertical between the stomach and the efferentijunal limb, greater length of the anastomosis, and a sutured rather than a stapled anastomosis were all things, technical things from the video that were associated with less risk of delayed gastric emptying. So this is a new way we could envision using video review for quality improvement and as part of predictive modeling for outcomes, because we're skipping this part when we just include the age and the pancreatic duct size. We're skipping what actually happened in the operating room. So when we talk about video-based assessments, if we're thinking about using this in the context of high-stakes decisions, then probably most would argue that some kind of expert review would be required, just like we have experts giving the oral exam, which assesses our judgment, and creating the written exam, which assesses our knowledge. And that would be important for the credibility, but I'm sure people have already done the math on this, and obviously using expert reviewers for all assessments challenges the feasibility and scalability of this approach. So for example, if you're talking about a VBA for general surgery initial certification, in the United States, for example, there's about 1,500 applicants. You need at least 2 reviewers for each of those videos. There's going to be appeals. If you add recertifications, that's 3,000 applicants a year. So that's not going to, it might be a great idea, but the feasibility is an issue. We also have people that are hawks and doves, easy raters, hard raters. How many raters do you need? So even if, plus the expense to compensate reviewers and so forth. So, and experts don't always agree. Well, there's a lot of literature about experts using these tools to assess anything. No, they don't always agree, shockingly. So this is where really the promise of AI models to automate some component of this comes in. And in order to even begin to develop these models, we need to have data from a lot of videos. So this gets us to artificial intelligence. So if you ask artificial intelligence to tell you what it tells you that it is, so like a Google search with their new AI at the top there, it tells you that this is the development of algorithms and computational models that enable machines to perform tasks usually requiring human cognitive abilities like reasoning, learning, and problem solving. And specifically, we're talking about a subset of artificial intelligence called computer vision, which is basically using algorithms to process imaging and videos, so basically allowing the computer to see. And we heard a lot of optimism this morning, so if you're an AI optimist, AI tools hold the potential to improve every aspect of surgical care. So we heard about patient prediction and postoperative prediction of outcomes, selection for procedures, and we're here talking about intraoperative potential for assessing performance, and there's many other applications. But we're at a research day, right? We're at a research day where we're supposed to be looking and evaluating evidence. So there's a total of 6 randomized trials in surgery with evaluating artificial intelligence. So we're in very, very, very early days. And 3 of those are about predicting hypotension in the operating room. And only 1 of them uses any kind of computer vision techniques. That excludes endoscopy. There's quite a lot of trials in endoscopy. So, but what about this concept? Can we think about how we could use AI to scale the use of video-based analytics? And the things that are checked off there are things that are already available. I think fairly widely available in a wide variety of these platforms. So things like privacy issues, so automatically removing identifying features, so blurring when the scope comes out of the body cavity, editing videos to just focus on the critical phases of procedures, instrument identification, phase recognition, so which column are you in of the operation, recognizing events like this is bleeding or this is bile, and some quality indicators like in lap chole, you've achieved the critical view of safety, or other safety indicators that we think are associated with outcomes. So these are all things, and I'll touch on them briefly, but that are already pretty much available. But here we're going to nuance a little bit of, can we use it to actually evaluate expertise? We're very early days on that one, but there are some very exciting data coming out. So what's already possible? So phase recognition, the ability of the algorithm to know what part of the operation is happening. So this is a systematic review. It's already a few years old, and it reviewed machine learning for surgical phase recognition, and this is just sort of so you basically how these algorithms are created. We have our data input from the operating room, video, as I mentioned, robotic motion, could be the instruments. These are then annotated manually, generally, by experts. So this is a dissection. This is a hemostat, a Maryland. This is the critical view of safety. And then the model is developed using machine learning on this annotated training set, and then the algorithm is tested on another set of videos. So even 5 years ago, there were already 35 studies reviewed. Just looking at this, laparoscopic cholecystectomy was the most common operation looked at, and accuracy rates were usually over 90%, and that was already 5 years ago. Several video storage and analytic platforms already incorporate AI phase recognition, like so you can see here what phase of the operation, and it can do this live. So as the video is being uploaded, it will tell you what phase of the operation it is, which you can imagine being useful for workflow issues in the operating room. Beyond that, of course, other groups have developed, which is very common, the ability to recognize safety practices, like I've achieved the critical view of safety, or adverse events like bleeding or bile, and this is already also something that's already a few years old from Stanford, and the AI surgeon agreement for the critical view of safety, like achieving all three components. Doesn't matter what that means, but a surgeon agreed with the AI was over 75%, and the AI annotated events like bleeding bile, there was basically perfect agreement with that. We're using this platform. I have a side gig in helping in donor nephrectomy. This wasn't going that well that day. And as you can see, the AI knows that this is a renal vessel injury with notable hemorrhage, and that this instrument, this hemostatic foam, was applied. This is not a person labeling this. This is the computer vision doing it, and basically in real time. And it went fine. That foam, I love it. And these kind of automated metrics are becoming much more sophisticated, going well beyond critical view of safety. Like these are some that this algorithm can identify for hernia. For colectomy, it can identify whether the ureter was identified, mesh overlap, whether you reduced a lipoma. I mean, it gets quite granular. And then you can start to see how a checklist approach to assessment could be feasible using these algorithms that are already available. So are we ready to have our performance evaluated by AI? We have to keep in mind a couple of considerations. So like any measurement tool, so the validity idea, is it actually measuring what we want it to measure, meaning technical skill or performance? And this gets back to how the algorithm was trained. So concept of supervised or unsupervised learning. So was it labeled by an expert? How is it labeled? If it's not done that way, then we don't really know what it's measuring, and we can't provide feedback to people to improve their performance. And we have to also look at, is it generalizable? What kind of data? What was the practice setting, disease complexity, and equipment that was used? Because the fact that it performs well on the data set, the training data set, will tell us very little about how it will perform in the real world. But there's already emerging body of evidence looking at evaluating machine learning for technical skills, but it's very early days. And I'm not an AI skeptic, I'm an AI optimist. But we also have to be scientists, and we have to look at where we are. This is a review identified lots of studies, 66 studies. But most were using to evaluate technical skill using computer vision and machine learning. But most of these were very simple benchtop tasks. And only 8 at this point were real surgery in the real operating room. And the data sets were very small. So 20 studies had less than 10 participants. I don't think they would make it to Gallie Day to present that at this podium. And really just the way you label performance is also something that you have to consider, like you're comparing a medical student with like an expert surgeon, so that's probably not that's like my video that I showed you. But accuracy overall were quite high, with more than 80% identifying, being able to differentiate a novice and an expert. And we're seeing really some exciting stuff coming out, though. We're seeing more and more sophisticated studies applying this to real surgery. This is a study developed where they developed a model to use automated metrics in robotic prostatectomy to predict length of stay. So the metrics are derived from the robotic interface. They represent things like instrument movements, camera motion tracking, and like energy use, so device use. And in this study from Stanford, the model was trained on 87 videos using the automated metrics, and each case was labeled as the length of stay was less than 2 days or more than 2 days. And when the trained algorithm was then applied to new cases, it could predict shorter length of stay with over 85% accuracy. So you can imagine coming out of the OR, looking at your phone, at your app, and having a prediction about, from the surgery itself, you could add clinical indicators as well, and having a prediction about this is a patient that could be discharged today and is not going to come back and is going to do very well. You can break down surgery to the level of surgical gestures that can serve as a novel method to predict longer-term outcomes. In this case, they were looking at same group, erectile function 1 year after prostatectomy. So gestures are like dissection technique, use of energy, use of 2 hands, and the gesture sequence were better able to predict 1 year erectile function than clinical features. This is just automated from the kinematics and video data from the operating room. Less use of hot cut, more use of peel push techniques were associated with better chance of erectile function recovery. So this may also start to be actionable, so things that can be emulated to improve results. And they also looked at gestures as sort of a signature of expertise. They compared 6 super experts who had done a median of 3,000 of these operations to 15 regular experts who had done 275 median. And super experts used fewer gestures, and they used more cold cut and less peel push and made fewer retraction adjustments. So this model recognized what a master surgeon's signature is. And finally, I want to just share this study that, from Japan that gets us closer to the potential use of AI to inform credentialing decisions. So to be certified in laparoscopic sigmoidectomy by the Japan Society of Endoscopic Surgery, surgeons submit videos that are judged by 2 surgeons using a video-based assessment that they call ESSQS. And this study looked at whether a deep learning model could be used to classify high and low scoring videos. So now we have a good video-based assessment. We have expert raters. Let's see how the AI does. And basically, their AI score was highly correlated with the expert video-based assessment. And they also showed that this screening, this AI output, could be used to screen. So it was good at screening for who was going to be in the low score group, with specificity was 93%, sensitivity 82%, or in the high scoring group. So you can imagine the potential for this would be to screen out those people that are going to score high and have the expert assessors really look at those more nuanced decisions, especially when we're talking about higher stakes assessments. So some of this stuff might be in the future, albeit the very near future, but it all starts with being able to store, access, and use video routinely. So we're using one of these platforms. As I mentioned, we're using it in 8 rooms at 2 main adult operating rooms. So how are we using this now? We use it at M&Ms to review the cases. And I do think it's like, having a CT, if you don't, not having this is a little bit crazy, because it's like taking a CT scan, throwing away the pictures, and just looking at just using the report when we're discussing, at M&Ms and how we can do better. When I see a patient who comes back and has a complication, I can review the video, or especially if I'm on call and I have a patient comes back that I didn't operate on, I can review the video. The residents and I can look at the videos and the analytics, the proportion where we've achieved the critical view of safety, how long it takes to find the ureter, things like that. Case preparation, so we all know that we prepare for cases by looking at YouTube videos. That's the #1 way that residents, for sure, prepare for videos. If I'm doing a case I don't do very often, that's the first thing I do is I Google it and look at a video. I'd rather our trainees look at our own videos, especially because they want to know how Dr. Okranik does it. They want to know how Dr. Manani does it. They probably do it all a little bit differently. So you come to the OR prepared. And of course, there's a lot of opportunities for research or editing videos for presentation. Now, in exploring, but I will say that there is very variable uptake. So there are some surgeons who love it. They record every single case. And there are surgeons that record none of their cases. And it's also different. At one of the sites, very high uptake, and at the other site, almost zero uptake. So in exploring these variations, surgeons raise many concerns and uncertainty with routine video recording. These include very important questions that we don't necessarily have the answers for. Ownership and access. Who owns a video? Is it part of the medical record? Are we using it for clinical care? If I'm reviewing it when a patient comes back with a complication, is that I'm using it for clinical care? What rights do patients, surgeons, institution, if the platform is a commercial platform, the platform itself, what rights do they have to the data in the video? Can they produce derivatives like AI models? Can they destroy the source material? Who can destroy it? Can this data be sold? Can it be shared? And if it's part of the medical record, then patients for sure have access to, do have the right to access their own records. There's concerns with privacy, for sure, with the patient. For a patient, we're uploading to a cloud, but also for the team, who are also being recorded, and trainees are being recorded. And if we're going to really develop these highly predictive models and using video streams as part of those predictions, it does have to be linked to clinical outcomes in some way. But we have lots of examples for other areas where we've overcome those issues. And liability implications are often raised. Is video good for the surgeon or bad for the surgeon if there's a lawsuit? And one could argue that we don't really agree on, there's no like one best technique to do something. And I would also argue that it provides evidence of good care. For example, this is just the last example I'm going to give. I was on call one time and a patient came back with a leak after a robotic sigmoid resection. This is the video. It was perfect. We have ICG, the perfusion of the colon and the rectum. We have, which was perfect. We have a leak test, which was perfect. We could see, I edited this, but you could see that, both the bowel was well perfused. We have the colon, we have a scope view of the anastomosis. It was perfect. So I would argue, yeah, this patient leaked, but I wouldn't say there was anything that could have been done differently, and I think that would be a video that would support that if that came to a liability issue, that best practices were followed. So to sum up, getting to mastery, what we can do now, I think, is, of course, getting back to the idea that operating is what differentiates us from other medical specialties. We and those people who came before us have dedicated our lives to learning and perfecting this craft. Operative performance can be measured from video, and it is associated with safety, like complications, and longer-term outcomes as well. Routine video capture, I think, should be standard now, and I think it will be standard. There's important implications for how it will impact education, potentially certification, quality improvement, culture, patient management, and of course, providing the data for these AI models. Developing these policy guideline standards for how we protect privacy in video, physician and patient consent, permissible uses of recording. All of these things, when we come together to develop them, will help mitigate the risks that are real. What does the future look like? So building high-quality AI models designed to augment surgical performance, so these are tools, requires large quantities of data with accurate labels. And we, as surgeons and experts, clinical experts, we need to be the ones defining those labels. So best practices and standards for performance that are defensible for summative assessment if we're using it for credentialing, and actionable for formative assessment. So they give feedback that can be used for coaching. And these are then going to require vigorous evaluation, like any technology or any innovation. And I think that lies with development of these tools, if they're going to help us and help our patients, require these development of these novel, collaborative, highly specialized interdisciplinary teams. And I think they're integral to this transformation of surgery that we're seeing now, and making surgery even less invasive, safer, and more personalized. So I thank you very much for the true honor of the podium today and being part of this day. I congratulate you all for the extremely high level of science that I get to listen to and enjoy. And I look forward to the rest of the day and, of course, the banquet tonight. Thank you.
Professor Feldman, what an amazing lecture. Thank you. It was really wonderful. And we have time for a few questions if there's any interest in the audience. Yeah, please use the microphones.
Thank you very much for your presentation, Dr. Feldman. I was a high school student at the Royal Victoria Hospital and decided to become a doctor, making rounds with someone one time. I've become very interested in patient advocacy in the last years, and it's being this whole transformation of AI assessment of surgical skill is being followed very closely by the patient community. And in many countries of the world, there are unofficial databases being maintained of surgeons and their abilities so that the patients are referring their newly diagnosed. So that this AI assessment, we had a lecture here by Andrew Wong at Rounds a few months ago, and the compartmentalizing of these gestures was fascinating to me. I'm quite interested in aging now as well, and full disclosure, I no longer operate. But can you tell us a little bit about not just the developing competency, but the aging surgeon assessing continuing competency? Is there any work in that area?
Yeah, so that was definitely, thank you for that question. As part of that American Board of Surgery pilot, and also you can see from the other study I shared with you, the Berkmeyer study, there's variability at every stage of practice. So in some ways, having more rigorous standardized assessments would probably be able to tease out differences no matter what stage we are at of the age, because we all know there are people that may have younger age and their performance is not where we want it to be. There are people at older age where their performance is fantastic. And so rather than using those kinds of proxy measures, you can get at the actual issue. But to do that, we have to have, that's why the road to creating these tools has to be very rigorous. So I think there is a potential role. And the people who participate in the pilot, I think about 2/3 of them felt it could play a role in identifying underperforming surgeons.
Hi, Dr. Feldman. I'm Stan Hamster. I'm one of the education researchers in our department. Thank you very much. I'm very interested in that validity question for board certification and so on, and high-stakes credentialing. And we've recently put a video recording system from SST in one of our ORs at Sunnybrook for orthopedic hip fracture surgery. But it's an open procedure. So I would like to have your thoughts about transferring or scaling what you've learned in sort of closed video contained environments or minimal access video recording to an open sort of environment. Has there been any work on that? And if so, is it more about video pre-processing or rater training, or where would you see the greatest challenge and what we should focus on in terms of trying to improve the validity of our data?
Thank you. It's a very good question. And it does come up quite a bit. I think you need another step to record an open procedure, whether we've tried like with GoPros. It's not ideal. So I think there's just probably some technology, but I think there are also commercial solutions. I think SST, but I don't know that, yeah. So there are some commercial solutions where I think they're trying to solve that, because after that, it's all the same. So just capturing the data, and we found in our little pilot trial too, it was before we had the automated upload and people had to record onto an external device and then upload. We missed 50% of the eligible cases that way. So having a better pathway to be able to collect the data. I think after that, I don't think that's really any different.
Great. Well, thank you again for an amazing lecture and for joining us.
Thank you. Thank you very much.
Very good. So we're going to take about 40-minute break for lunch, and then at 12:30 we'll resume the next session of the e-posters for an hour, and then we will reconvene back here at 1:30 promptly for the student trainee presentations. Thank you.